Welcome to the video on conditions of disorders of the hip joint. We will discuss common causes, diagnostics and treatment options available. Feel free to subscribe to the channel. For more videos on orthopedics in adults, check the playlist in the description below. The information presented in the video is intended for medical education and informational purposes only. It is not suitable for professional medical advice, diagnosis or treatment. Please consult with your healthcare provider before making any decisions regarding your health and treatment options. The views and opinions expressed in this video are solely those of the presenter and do not necessarily reflect the official policy or position of any healthcare organization or institution. Osteoarthritis of the hip joint, also known as coxarthrosis, is a common condition that affects more women than men. It can arise from primary, idiopathic or secondary causes. Primary coxarthrosis typically occurs in old age and may have a genetic predisposition. Secondary coxarthrosis is caused by an abnormal mechanical relationship in the hip joint or inflammation of the hip joint. Symptoms of coxarthrosis include pain, decreased mobility, and reduced load-bearing capacity. Diagnosis is based on medical history, physical examination, X-ray examination, and sometimes additional laboratory testing. The history. Pain caused by disorders of the hip joint can be experienced in the groin, radiate to the thigh and the knee, and sometimes be felt in the greater trochanter or buttocks region. Initially, pain may only occur during activity, but as the condition progresses, it can become more constant, even at rest or at night. In addition to pain, loss of function is a common symptom, with patients experiencing reduced walking distance and difficulty with activities of daily living, such as putting on shoes and socks. Muscular hypertonia, reduced muscle use, muscle atrophy, and the development of osteophytes can all contribute to pain and loss of function. The anamnesis. Although functional limitation, in particularly internal rotation, is already demonstrable in the early phase, the patient initially notices little of this because the flexion of the hip joint can maintain normal for a relatively long time. Only with the increased limitation of hip flexions do problems arise because the patient has problems putting on shoes and socks. Sexual problems can also arise, which are only rarely reported spontaneously as such. The pain disrupts the walking pattern and the patient tries to avoid the pain by using the leg less. This becomes visible in various forms of limping. In severe coxarthrosis, apparent leg length differences can also occur, particularly due to contractures. Physical examination. Groin pain radiating to the upper leg is a strong indication of intra-articular hip pathology. This means that the pain is coming from within the hip joint itself, rather than from the soft tissue surrounding it. Neurogenic or vascular abnormalities should always be included in the differential diagnosis of hip pain. This is because nerve or blood vessels problems can also cause pain in the hip region. Limitations of internal rotation of the hip is often present in early course of the disease. This means that the patient may have difficulty rotating the hip inward. If the pelvis is not sufficiently fixed during the physical examination, an overly optimistic impression about the mobility of the hip can easily be obtained. This is because the examiner may be able to move the hip more than the patient can actually do on their own. The walking pattern. Hip disorders are often recognizable from a distance. Normally, the walking pattern is symmetrical. Both legs are equally loaded and the stride length is the same on both sides. Due to pain and functional limitations, the stride length of the affected side becomes shorter. Sometimes a cane is used to reduce the load on the affected hip and to cause fewer complaints. The pain causes an insufficiency of the gluteal musculature, as a result of which the pelvis can no longer be kept horizontal while standing and walking, but instead sags toward the affected side, in a Trendelenburg gait. Sometimes the patient tries to compensate for this by raising the center of gravity of the body above the hip, which is visible in a sideways swaying of the trunk during walking. This is called a Duchenne's gait. This reduces the mechanical load on the hip and therefore the pain. Standing diagnostics. First, check whether the pelvis is upright. The pelvis should be horizontal in the frontal plane. This can be checked by simultaneously palpating the anterior superior iliac spine on both sides, and further verified by palpating the posterior superior iliac spine on both sides. Sometimes discrepancies are found due to the pelvic asymmetry or contractures. If there is a suspicion of a leg length difference, an attempt will be made to quantify the size of this leg length difference with planks or different thickness under the foot. The leg length difference can be further checked later during examination in lying position. With a flexion contracture in the hip, the patient either stands with a flexed hip on the affected side or tries to correct this by assuming an increased lumbar lordosis. The Trendelenburg test can be used to check the strength of the abductors, particularly the gluteus medius and minimus muscles. These ensure the lateral stability of the pelvis. A positive Trendelenburg test may be the result of following factors, among others: a painful hip, unfavorable mechanical conditions around the hip, such as congenital hip subluxation or pseudoarthrosis after a fracture, shortened femoral neck, abductor muscle palsy, as may be seen in several neurological disorders. Examination of the hip in supine position. The evaluation of hip disorders commences with a thorough examination of the pelvic position, leg length, quadriceps muscle atrophy, and hip mobility. To assess pelvic position, the examiner observes whether the anterior subiliac iliac spines are level on both sides. The size of the quadriceps muscle is also assessed as a measure of muscle atrophy. Atrophied quadriceps muscles can indicate a long-standing hip disorder that has limited mobility and strength in the leg. The hip region is inspected for any discoloration, swelling, or other abnormalities. The hip joint itself is not directly palpable due to its deep location with the musculature, but the greater trochanter, a prominent bony landmark on the lateral side of the hip joint, can be palpated. Pressure pain over the greater trochanter may suggest trochanteric bursitis, an inflammation of the bursa, a fluid-filled sac that cushions the joint. Additionally, a clicking sensation may occur when the legs alternately internally and externally rotated in an adduction position, a sign of a snapping hip, caused by friction of the iliotibial band, a tendon that crosses the hip joint over the greater trochanter. A routine examination of the lower extremity also includes an exploratory back examination to rule out any spinal cord abnormalities that could contribute to hip pain and limited mobility. Peripheral positions are checked to ensure adequate blood supply to the lower extremities. The ultimate assessment of the mobility of the hip involves active and passive movement examinations. Active movements are those initiated by the patient, while passive movements are performed by the examiner. It is crucial to ensure that the movements occur primarily at the hip joint itself and not by compensating with pelvic movements. Rotations in the hip can be measured both in the extended and flexion positions, and the flexion and extensions are also assessed. The difference in range of motion between the two hip joints can provide valuable clues about the nature and extent of any joint pathology. The next chapter is on X-ray examination. History and physical examination usually provide sufficient clues to make the probable diagnosis of coxarthrosis. However, especially when the complaints persist for more than a few months or are progressive or severe, it is recommended to confirm the diagnosis with X-ray examination. In the case of coxarthrosis, the hip joints are assessed for joint space narrowing. Furthermore, cysts and sclerosing in the femoral head or acetabulum are regularly visible, as well as osteophytes along the joint edges. One must always be aware of other types of disorders in the hip or pelvic region. The next chapter is on additional imaging studies. Initial diagnosis based on X-ray, physical examination, and medical history. Further imaging or laboratory testing may be needed if X-rays are inconclusive. Technetium scintigraphy is used for suspected oncological or infectious processes, while gallium and indium scintigraphy are more specific for infections. MRI is accurate for both soft tissues and bones, especially for avascular necrosis of the femoral head, and CT scans are preferred for fractures or post-traumatic deformities. PET scans and ultrasounds have limited applications in adult hip pathology, and arthroscopy may be necessary for the diagnosis or treatment, especially for removing loose bodies, peripheral calcifications, or labral tears. The next chapter is on laboratory research. In addition to a local cause, localized complaints can also be related to systemic disorders. Differentiation between degenerative disorders on the one hand and infectious, oncological, or metabolic disorders on the other may be necessary in less specific cases. Initially, the blood tests include determination of hemoglobin levels, hematocrit, leukocyte level with differentiation, ESR, and CRP. When rheumatic diseases are suspected, they are supplemented with the determination of rheumatoid serology. Research into the types of disorders is highly specialized, and the discussion therefore is beyond the scope of this video. The next chapter is on arthrosis deformans. The development of arthrosis deformans can be attributed to various pathophysiological mechanisms, broadly characterized into primary or idiopathic coxarthrosis, where the underlying cause remains unknown. The other category is secondary coxarthrosis. Secondary coxarthrosis encompasses a range of factors, including congenital hip disorders such as dysplasia and dislocation, acquired hip disorders such as Pertus disease, epiphysiolysis, capitis femoris, and various arthritides. Post-traumatic abnormalities arising from fractures of the column femoris, femoral head, acetabulum, or pelvis, avascular femoral head necrosis, tumors, chronic mechanical overload due to sports or work, and rheumatoid arthritis. Primary arthrosis deformans. The incidence of coxarthrosis increases with age, and in old age, osteoarthritis is often seen where no other underlying pathology is found. This is often referred to as primary coxarthrosis, where it is assumed that age is the causative factor. However, there are also patients in whom this osteoarthritis develops at a relatively young age, with otherwise anatomically normal hip joints. By exclusion, one then speaks of primary or idiopathic form of coxarthrosis. Frequent occurrence in certain families presupposes a genetic component in a number of cases. This may be due to congenital defects in the cartilage metabolism. In 30% of cases, such a form of coxarthrosis is bilateral, although not always synchronous. The condition occurs more often in women than in men. Congenital hip defects. Congenital hip dysplasia is characterized by an underdevelopment of the acetabulum, resulting in a partial contact between the femoral head and the acetabulum. This leads to increased pressure on the cartilage and can cause premature osteoarthritis. Screening for hip abnormalities in newborns and early treatment are crucial to prevent these complications. Congenital hip dislocations occur when the femoral head is displaced from the acetabulum at birth or shortly thereafter. This condition causes several functional impairment and, if left untreated, leads to the development of neoacetabulum, a shallow socket-like structure that can lead to premature osteoarthritis. Adequate screening in childhood has significantly reduced the incidence of untreated congenital hip dislocation. Acquired hip disorders. Acquired hip disorders can develop at any age and can lead to premature osteoarthritis, regardless of the treatment. These disorders can cause lingering symptoms that can persist for decades. Childhood conditions like Pertus disease and epiphysiolysis capitis femoris can lead to premature osteoarthritis. Other factors that can contribute to osteoarthritis include bacterial or non-bacterial arthritis, fractures in the hip region, avascular femoral head necrosis, tumors, and chronic overload. Pertus disease is a childhood condition caused by circulatory problems in the femoral head, leading to osteonecrosis. This can result in the collapse of femoral head and shape incongruity. Epiphysiolysis occurs when the femoral head slips from its growth plate, typically during the puberty growth spurt. Dorsal slippage can lead to the deformity and increase the risk of osteoarthritis. The natural course of osteoarthritis of the hip. The temporal course of osteoarthritis can be very variable. This partly depends on the cause. In post-traumatic disorders or in an inflammatory condition, the course may be months or years, while in more idiopathic forms it may extend over several decades. In general, arthrosis deformans is not an inevitable one-way downward process, but there is always a delicate balance between destruction and reparative processes. This can be addressed with adequate treatment. The next chapter is on conservative therapy. The treatment of arthrosis deformans is focused on the stage of the condition. The most important parameters are pain and limitations. X-ray abnormalities are only an indicator of severity of the condition and not an objectification of the complaints. They are not in themselves an indication of treatment. In the initial phase of arthrosis deformans, treatment will be predominantly conservative, consisting of advice and lifestyle rules, whether or not supported by the measures such as medication, physiotherapy, or exercise programs. The rules for life. Effective osteoarthritis management involves balancing the patient's hip load and load-bearing capacity. Pain-provoking activities, particularly rotational movements, should be avoided due to the common limitation of the rotation. It's crucial to educate the patients that while exercise is beneficial for arthritic joints, excessive activity can exacerbate pain. Encourage them to listen to their bodies and rest when needed. Addressing obesity can also be beneficial. However, weight loss often presents a challenge, as it requires both reduced food intake and increased exercise, which can cause pain. Patients often find that cycling is more comfortable than walking, and cycling, including on an exercise bike, is an excellent way to maintain hip flexion. Swimming can be complemented for cycling by promoting extension and rotational movements. In severe cases, a walking stick on the unaffected side can be prescribed. This reduces the load on the affected joint by over 50% during the stance phase and often significantly reduces pain. And during acute pain exacerbation, lifestyle modifications can be supplemented with pain medication. Medication. There are yet no medications that can slow the progression of coxarthrosis. Pain medication is therefore at most symptomatic and may therefore only be prescribed temporarily. By reducing pain, the patient can try to escape the vicious cycle of pain and reflex inhibition by rebuilding muscle and thus improving the conditions of the joint. Paracetamol or NSAIDs, in more advanced cases, are suitable for this. The danger is that pain as a warning signal is suppressed and potentially harmful activities can then be undertaken. Physiotherapy also has a place in the build-up phase. Physiotherapy. Massage is only useful as an aid for pain relief and preparation for exercise therapy. This also applies to the physiotherapy in the narrower sense, which uses equipment. The most important function of physiotherapy is to teach patients how to keep their joint in the best possible condition, despite the presence of limiting factors. The most important part is targeted exercise therapy to combat existing contractures or atrophies. The next chapter is on surgical therapy. Indications. When conservative treatment fails to provide adequate relief, surgical intervention for hip osteoarthritis may be considered. The decision-making process is complex and influenced by various factors, including pain severity, activity limitations, age, living conditions, psychosocial factors, and X-ray findings. The primary goal of the surgery is to alleviate pain and restore hip function, and joint preservation is prioritized, especially in younger patients. Surgical procedures like proximal femoral osteotomy and periacetabular osteotomy can slow the progression of the osteoarthritis. Joint sparing operations. Hip arthrodesis or fixing is a primary treatment for coxarthrosis that is only rarely used today. It is still a good option for very young patients with serious hip problems, but it is often difficult for patients to accept the idea of stiff hip. Hip arthrodesis is a relative contraindication for patients with a history of serious infection problems, serious soft tissue damage, or dysfunction around the hip. Joint sparing operations are indicated for patients with osteoarthritis that has not progressed too far, but is causing symptoms with radiological proven progression. These operations are typically performed on patients under 40 or 50 years old. In older patients, it may be better to continue conservative treatment for a while longer and then proceed with a hip prosthesis. Joint sparing interventions can slow the progression of osteoarthritis for many years, but they can only rarely prevent the eventual need for prosthetic implantation. Hip osteotomy is a procedure that is still performed to slow the progression of coxarthrosis. The hip osteotomy was introduced by McMurray, and the biomechanical foundations were further developed by Powell's. After the osteotomy, the load per unit area decreases, which favorably influences the balance between the breakdown and the repair of cartilage. The patient is mobilized with elbow crutches after a few days and can leave the hospital. The hip will need to be relieved for several months to consolidate the osteotomy and support the recovery of the arthrotic process. After 3 months, the hip can generally be fully loaded. The beneficial effect on the arthrotic process usually lasts for many years and sometimes more than 10 years. Periacetabular osteotomy is a procedure that is suitable for patients with osteoarthritis that is largely the result of hip dysplasia. These procedures are preferably performed in childhood, although they can occasionally be considered in young adulthood for mild forms of hip dysplasia. And during the procedure, one or more bone chips from the cristae are placed extra-articularly directly above the acetabulum. This improves the support surface for the femoral head, reducing the effective load per surface. More severe forms of hip dysplasia may require periacetabular osteotomy. Two variants of this are known, including the triple osteotomy according to Tonis and the periacetabular osteotomy according to Gans. These are very complex procedures that must therefore only be performed in centers with a lot of experience, if strictly indicated. The next chapter is on total hip replacement. Total hip arthroplasty has become a widely adopted surgical procedure since the 1960s, revolutionizing the treatment for hip osteoarthritis. Sir John Charnley's cemented hip prosthesis remains a cornerstone of modern orthopedics. Approximately 25,000 hip arthroplasties are performed annually in the Netherlands, primarily for coxarthrosis. Various types of prosthesis exist, categorized by fixation methods and articulating surface materials. Modern hip prostheses replace both the acetabulum and femur. In older patients, head and neck replacement may suffice in acute fracture treatment. And this chapter delves into the following aspects of hip prosthesis: the types, fixation methods, bearing metals or materials, surgical techniques, outcomes, complications, and long-term issues. Types of hip prosthesis. Hip prostheses are essential for pain-free functioning and must be securely anchored in the surrounding bone. They are typically inserted into the medullary cavity of the proximal femur and fixed to the endocortical bone layer. Three main types of prosthesis exist: cemented, uncemented, and resurfacing. Cemented prostheses use bone cement for fixation, while uncemented prostheses rely on direct bone ingrowth. Resurfacing prostheses, once popular among young patients, have been discontinued due to safety concerns. Most modern prostheses are modular, allowing for customization during surgery. Cemented prostheses have excellent outcomes in older patients, but results are less favorable in younger patients. Uncemented prostheses have not shown superior long-term survival in younger patients compared to cemented prostheses. The main challenge with both types is the poorer long-term survival of the hip socket. The resurfacing prosthesis, also known as the sports hip, is a type of hip replacement that is anchored to the mild femoral head with bone cement. It was initially used in the 1980s but discontinued due to the issues with the polyethylene cup. Resurfacing prosthesis utilizes a metal bearing between the head and socket components and is claimed to offer a higher activity level for young active patients compared to conventional total hip prosthesis. However, serious concerns have emerged regarding its safety, prompting the Dutch Orthopedic Association to advise against its implementation as of 2012. The failure rates of these prostheses are often higher after 5 years compared to traditional prostheses with a femoral stem. Additionally, the combination of a large metal ball and metal bowl can lead to metal wear, releasing high concentrations of chromium and cobalt, which can cause local pseudotumor formation and systemic abnormalities. The hip prosthesis operation. Hip replacement surgery, while now a commonplace procedure, still demands meticulous preparation and adherence to specific protocols to ensure optimal outcomes. Infection prevention is paramount, necessitating stringent sterile conditions in the operating room and prophylactic antibiotic administration. Patients must be free from active infections elsewhere in the body to minimize the risk of hematogenous contamination of the prosthesis. Pre-existing infections in the teeth, bladder, or skin must be thoroughly treated prior to surgery. Thrombosis prevention is another crucial aspect of hip replacement surgery. A routine peri- and post-operative anticoagulation regimen is typically implemented for 4 to 6 weeks to reduce the risk of blood clots. The surgical technique itself can be performed under general, epidural, or spinal anesthesia. The choice of surgical approach, either posterior-lateral, lateral, or anterior, depends on the surgeon's preference and the patient's anatomy. Postoperatively, patients are mobilized the following day and encouraged to walk with partial or full weight-bearing support and crutches. A global recovery of function is expected within 3 months, but patients with severe pre-existing contractures or muscle atrophy may require more time and physiotherapy guidance. During the first 3 months postoperatively, the joint capsule, which stabilizes the hip joint, undergoes healing. To prevent dislocation during this period, patients should avoid excessive adduction or rotation of the operated leg. Raising the bed and toilet and avoiding low chairs can further aid in dislocation prevention. In conclusion, hip replacement surgery, while now a standard procedure, requires careful preoperative preparation, adherence to infection and thrombosis prevention protocols, and appropriate postoperative care to maximize patient outcomes and ensure a successful recovery. Long-term results. Modern types of hip prosthesis have proven to be very successful. In patients older than 65 years, the survival of cemented prosthesis after 10 years is approximately 95%. Survival is less favorable in younger patients. After 10 years, 70 to 80% of the prostheses are still in situ. Recent studies show that uncemented hip prostheses unfortunately do not perform better in these younger patients than a well-cemented hip prosthesis. For both types, stem survival is acceptable with percentages of 95% after 10 years and 90% after 15 years. For both methods, the results on the acetabular side are less good. Cup survival in young patients is 80 to 90% after 10 years, and the number of cup failures increases rapidly with the longer follow-up than 10 years. Regardless of the type, the lifespan of the hip prosthesis is largely determined by the patient's activity level. The media attention to everything related to prosthesis suggests that patients with an artificial hip can do everything again. This appears to be the case in the short term, but the damage accumulates and it is at the expense of the ultimate lifespan. Although a hip prosthesis is suitable for everyday activities such as walking, cycling, swimming, and light occupational activities, it is unsuitable for heavy work or intense sports. Patients must be adequately informed about this. Complications of hip replacement surgery. Hip replacement surgery, despite its advancements, is not without its complications. These include thromboembolism, infection, dislocation of the prosthesis, periarticular calcifications, nerve or vascular injury, fracture or perforation, and leg length discrepancies. Thromboembolism, the formation of blood clots, can occur despite preventive measurements like anticoagulants. Calf vein thrombosis is particularly common, sometimes requiring stricter anticoagulation. However, excessive anticoagulation can lead to increased bleeding. Infections can manifest shortly after surgery or up to 2 years later. Early infections often result from surgical contamination, while later infections may arise from hematogenous spread from other infection focus. Symptoms include vague pain, wound healing issues, elevated ESR and CRP, and sometimes fever. Early treatment with wound care, antibiotics, and prosthesis removal may be necessary. And persistent infections may require multiple surgeries and even permanent prosthesis removal. Dislocation of the prosthetic head from the socket can occur in up to 3% of cases, particularly in early postoperative phases. Provocative movements like getting up from a deep chair, overextending the hip, or twisting during bed transfer can trigger a dislocation. Repositioning under muscle relaxation or anesthesia is usually successful, and recurrent dislocations may require a protective hip abduction brace. Periarticular calcifications, abnormal calcifications around the surgical area, can cause persistent pain and limited hip function. Prophylaxis with NSAIDs during the first week after surgery may be helpful, but severe calcifications with movement restriction may require surgical removal. Nerve or vascular injury is uncommon, with nerve injury risk typically below 1%. However, the risk increases with more complex reconstructions, reaching up to 5% in hip dysplasia surgery. Nerve injury may manifest as neuropraxia, which can recover in the first few months postoperatively, and vascular injury, while rare, is potentially fatal. Addressing leg length discrepancies is a common goal of hip replacement surgery. However, it may not always be achievable due to abnormal tissue tension, especially in cases of pre-existing deformities, and excessive muscle tension can hinder function. With proper planning and execution, leg length differences can usually be kept to 0.5 to 1 cm, which has no clinical consequences. Computer navigation for prosthetic placement is an experimental technique that may further improve its accuracy. Its added value and cost effectiveness are still being evaluated, and its adoption is slow due to the time-consuming process. The next chapter is on problems with hip prosthesis. Causes. Modern hip prostheses, whether cemented or not, are designed to be pain-free shortly after surgery, with significant functional improvement by 3 months, achieving at least 90 degrees flexion, and often more. Only recovery from severe pre-existing contractures or muscle atrophy may take longer, up to over a year. Persistent pain or pain returning after an initial free period warrants further investigation. Early on, infectious complications are the primary concern, while mechanical loosening becomes a consideration in the longer term. Habitual prosthesis dislocation is another potential issue, and pain may also arise from sources other than the hip. The differential diagnosis of a painful hip prosthesis includes a low-grade infection, mechanical loosening, synovitis due to the prosthetic material wear, impingement due to the malposition of the prosthesis, functional limitations caused by periarticular calcifications, soft tissue problems, low back problems with referred pain to the hip region, and vascular problems. Research. Additional examinations are often needed to distinguish prosthetic problems. Blood tests, X-rays, scintigraphy, arthrography, and aspiration cultures of the prosthetic joints are among the tests that can be performed, especially when there are severe symptoms or a suspicion of septic or mechanical loosening. Infection parameters in the blood may suggest an infection, but they may not always be abnormal in low-grade infections. X-ray reveals the position and quality of fixation of the hip prosthesis. A loose prosthesis is surrounded by radiolucent lines and may collapse over time. Wear problems of the PE bearing or cup, osteolytic reactions, or abnormal calcifications near the prosthetic parts can also be detected. Scintigraphy can provide further clues if an infection is suspected after the first year. Aspiration cultures of the prosthetic joints performed under sterile precautions can further confirm the diagnosis of infection. A hip puncture may also be combined with arthrography of the joint, which can also reveal less obvious forms of loosening. A diagnosis can usually be made after these examinations, and it can be determined whether reoperation is necessary. Reoperation is indicated for septic or mechanical loosening of the prosthesis part, along with sufficient clinical symptoms or severe progressive bone loss, with a risk of fracture of the bone around the prosthesis part. Revision of the hip prosthesis. Revision of a loose prosthesis is a complex procedure with many problems and pitfalls. The loose prosthesis has usually caused more or less serious bone loss. The bone loss can be exacerbated during the removal of loose prosthesis, which is not always easy to replace. The core problem is that a new prosthesis must be implanted in bone that has been significantly weakened. The main problem of revision surgery is therefore the restoration of bone quality. As a rule, a bone transplant will therefore have to take place in addition to the replacement of a new prosthesis. In this way, a reasonable balance is achieved between the load-bearing capacity of the bone and the prosthesis. Specific revision prostheses and techniques are often required, and complication rates after revision surgery are higher, but with good technique, very adequate results can be achieved, although rarely as good as with a successful primary intervention. Other hip disorders. Bacterial arthritis and osteomyelitis. Bacterial arthritis is a serious infection that can quickly damage the joint, especially in children under the age of 4. If left untreated, it can lead to poor hip function, growth disorders, and length differences. Early diagnosis and treatment are crucial to prevent these complications. Symptoms of bacterial arthritis include fever, leukocytosis, elevated ESR and CRP, with local symptoms of pain, warmth, and swelling. Imaging tests such as X-ray, ultrasound, MRI, and technetium scintigraphy can help with the diagnosis. Treatment typically includes surgery to drain the infection and antibiotics to kill the bacteria. An early intervention is key to prevent joint destruction. Hip disorders in systemic and inflammatory disease. Hip joint involvement is a common complication in various systemic inflammatory conditions, posing diagnostic and therapeutic challenges. Rheumatoid arthritis frequently affects the hip, leading to secondary arthrosis deformans. Early treatment is crucial, and advanced cases may require total hip replacement. Ankylosing spondylitis primarily affects the axial skeleton, including the sacroiliac joints, the spine, and sometimes the hip joints. Symptoms include lower back pain and limited mobility. Treatment involves drug therapy, exercise therapy, and potentially total hip replacement. In Crohn's disease and ulcerative colitis, hip arthritis occurs in a minority of cases, but it can be rapidly progressive, necessitating hip prosthesis. Other systemic conditions affecting the hip joint include ochronosis, psoriatic arthropathy, lupus erythematosus disseminatus, Gaucher's disease, acromegaly, and hypothyroidism. Avascular femoral head necrosis. Avascular femoral head necrosis is a condition in which the femoral head, the ball-like part of the hip bone, dies due to the lack of blood flow. Traumatic avascular femoral head necrosis is caused by a hip injury, while non-traumatic avascular femoral head necrosis is caused by a combination of genetic and lifestyle factors. Timely surgical treatment with drilling fourage of the lesion in the initial phase, or bone grafting in combination with a vascularized bone graft in more advanced stages, are attempts to preserve the femoral head. If a total collapse occurs, it's not uncommon, Then only a total hip replacement can provide a solution. Trochanteric bursitis is an inflammation of the trochanteric bursa, a fluid-filled sac that cushions the hip joint. It is caused by an overuse or repetitive motions. Symptoms include pain, tenderness over the hip joint, and the differentiation as well as a trial treatment are possible with local infiltrations using lidocaine. In typical cases, this can be combined with a therapeutic locally acting corticosteroid at intervals of 4 to 6 weeks. If the condition recurs, splitting or lengthening the iliotibial band can sometimes provide relief. In recent years, it has been assumed that a significant proportion of patients suffer from pain caused by an insertional tendinopathy of the gluteal muscles that insert on or near the greater trochanter. That is why the term trochanteric pain syndrome is increasingly used. Snapping hip. Sometimes a click occurs over the lateral side of the hip. This is usually caused by a somewhat abnormal course of the iliotibial band. During flexion and extension of the hip, such as during walking, the tract jumps from ventral to dorsal over the lateral side of the greater trochanter. This is also palpable on examination. The phenomenon can only be induced by active tension of the musculature. Pain complaints are rarely prominent, so reinsurance rather than treatment is needed. If the clicking is very bothersome, cleaving or lengthening of the iliotibial band can be performed, and in rarer cases, clicking can also be caused by other structures, such as the psoas tendon on the ventral side of the hip. Rarer hip disorders. Pigmented vilonodal synovitis is a rare benign tumor of the hip joint's synovial lining. It causes nonspecific and vague symptoms. X-rays may be normal in the early stages, but later show cyst formation on the femoral neck, and MRI scans can detect iron pigments in the synovium. Diagnosis is confirmed by arthroscopic biopsy, and treatment involves synovectomy of the hip joint. Synovial chondromatosis is another rare hip condition that causes loose bodies to form in the synovium and shed into the joint. Symptoms are often nonspecific, and X-rays show loose bodies in the joint. And treatment is synovectomy of the hip joint. You can show appreciation for the content by liking, subscribing, or commenting on the video.